Right, so I see there's still some more people trickling in, but we'll just make a start. We've got quite a busy agenda, but thanks everyone for attending this learning session. Thanks a lot for your interest in participating in it. I'd like to say thanks to our speakers as well, not just for being available today, but for freeing up their time earlier in the month to discuss their stories with us and help us capture them in the form of some short case studies. And we've also put together a bit of a resource that briefly describes the learning that we feel is common to each of the stories. And I guess as we go through this session, I think it's the important thing to remember about developing interface guidance is that although it's a process, it shouldn't necessarily be seen as something that's unnecessary or extra work. What you'll hear in these stories today is that these conversations are happening all the time between clinicians and managers about where someone may receive the best care, who's best placed to provide it, what interventions will be most likely to work. And I'm sure in many different forums, such as in your operational meetings or staff development sessions or adverse event reviews, many of the same things will be coming up as well around communication between services, around information sharing, around awareness or lack of awareness of what's going on for people, risk factors they might have, life triggers they may experience, what causes them to disengage or go missing from services. So I think, when we think about this in the round as a starting point, you might want to just look at what you're able to do to give shape to some of the conversations that already take place and to provide spaces for them, whether they be formal or informal. A mixture of both is probably the best, as you'll hear throughout the stories. And leadership support can enable staff to problem solve and to try things out, to do things differently. And appropriate governance structures can give visibility to the efforts of staff and help to understand the difference that this is making. And I think another key thing to draw out here, and again, it will be drawn out in the presentations, and I'm sure it'll be drawn out in the breakouts as well, is just the importance of paying attention to relationships. So what is the impact of what you're doing on relationships between people accessing services and people providing care? Because at the center of good care is positive therapeutic relationships. And then equally important is looking at the relationships between services, between staff, and how they can be developed further. Successful joint working will require positive professional relationships. And if clinicians can build better relationships within and across services and systems that they work within enable these efforts, then they'll be able to share information more easily. And both people accessing care and clinicians can be more confident in asking for and receiving the help when required. So hopefully through the presentations, you'll spot existing opportunities that can be used to improve not only outcomes for people with co-occurring mental health and substance use conditions, but also the day-to-day experiences of staff providing care. So I'll hand over to my colleague Gregory in a minute. I'm Benjamin McAwee, Senior Improvement Advisor for the Mental Health and Substance Use Programme. And Gregory will talk you through the housekeeping and the rest of the session.
Hi, yeah, thanks for that introduction there, Benjamin. Yeah, so I'll be kind of taking us through a lot of the session today. We just wanted to get started with some housekeeping. So it's quite a big webinar here. So just to let you know, if you're having any technical difficulties, then please contact Abby Tomlinson, who via MS Teams should be able to get the message there or through an email if that's easier, and she'll be able to sort you out there. In terms of just kind of going through the MS Teams settings, I'm sure we're all very aware of this now, but just in terms of, you'll see there opening and closing the chat panel. So you can use the chat to introduce yourself, raise any questions you've got, and also post comments. It'd be really useful to hear kind of any thoughts that are coming up as we're going through. In terms of accessibility, feel free to put on any of the accessibility features required, such as the live captions. You can mute notifications, including the chat, if that and the lobby as well. And you'll see that if you click on more and the settings and accessibility, and also those muting the notifications. So cameras and microphones will be automatically switched off, except during the Q&A sessions. And yeah, if you need to leave at any time, then feel free to do so. In terms of the Q&A, so we're there's a Q&A feature on Teams that we would encourage you to use if you do have any questions. Benefits of this is that you can put your question in and other people can sort of vote if that's a question that they're also thinking about as well. They can comment and they can react to that as well. So we'll be keeping an eye on that, and then at the panel session at the end, we'll be bringing those questions in. We'll also be any questions that we don't get to, we'll be sharing with the speakers and ourselves, and we'll put the answers to those in the sort of post-event communications. So yeah, feel free to familiarize with that. The session will be recorded and the link shared so that people who are unable to join us today, they can listen and watch the session. However, during the panel discussion, we'll stop that recording and we'll not capture the camera or the audio of attendees during this part of it. So then, yeah, the agenda for today, welcome and introductions. Again, thank you very much for that. So, talked about the interface guidance. So we'll go through basically thinking about the interface guidance as a bit of a starting point for where we want to get to and how that kind of sits in the context of mental health and substance use, and specifically the sort of mental health and substance use interface. The protocol in terms of that bigger picture of things. Then we're going to hear from Ross and Leanne about the development of their interface guidance and specifically how they kind of built that case to make sure that it was seen as a visible and important piece of work within what we know is quite a busy landscape. We're going to be hearing from Laura and Lindsay from West Lothian about how they supported that dialogue and developed that shared understanding. Again, thinking about what Benjamin said around that thing, that it is iterative, these conversations are happening. We'll have a quick comfort break at that point, and then we'll come back here for 3, where we'll hear from Peter and James from North Ayrshire Health and Social Care Partnership around looking at the role of leadership in implementation and kind of putting that structure around that and how that can be and used, and the benefits of having that really strong leadership there. We'll then have breakout discussions. So you'll be kind of assigned breakout rooms, and basically really that's just an opportunity to speak to other people, to identify if there are people in the breakout room who do have interface guidance and potentially ask questions and get advice around that, but also share reflections on what you've heard so far from the examples around things like what conversations are you having at the moment that you think could become a bit of a foundation for wider discussions that might lead to interface guidance, or whether you might have it already, and what kind of issues or things you're having around kind of the implementation. We'll then have our panel discussion, and then we'll close out with a bit of a call to action and a bit of a so what for the session, and then we should be all good and set and happy at 4 p.m. to finish. So this, the session and the interface guidance. So this is, the first of our kind of webinars around the mental health and substance use national protocol, which, for those of you who don't know, came from recommendations around making sure that there is a clear protocol for how services need to support people and what a system of care looks like for supporting people with co-occurring mental health and substance use needs. So it's got kind of 5 core components that we've been talking about and that are in that, and it's looking at joint decision making, joint working, and transition. So that's looking at how you create these joined up approaches that are able to be responsive and provide seamless care for people who are accessing multiple services and have these co-occurring needs. Leadership and culture change, again, to look at in terms of that implementation, making sure that there is this culture of kind of collaboration, collective responsibility and things like that, to support that. There's quality management system part of it as well, so it's making sure that there's accountable governance structure and that it's based on learning, so that and again you'll hopefully hear that coming out of the presentations today about that idea of kind of making sure you're listening and learning and refining as things go. And then enabling better care. So this is a lot of this is centered on making sure you've got an empowered and enabled workforce who have the right skills and are supported to feel confident in using those skills. And then there's the whole system planning and delivery, which is about how you align activity and priorities within strategies and change occurring. Because again, that comes back to this idea that there is quite a lot happening, and it's making sure that this is they're all kind of rationalized and they're supporting each other. So really, the kind of key points in terms of what recapping the protocol, it is about bringing together existing standards and requirements into a protocol for implementation, because a lot of the stuff that I've just described, there's guidance and there's standards around that already, particularly in this case, thinking about sort of MAT standards. There's a lot of work around ethical commissioning at this point as well. So it's bringing that together and looking at specifically how does that relate to this particular cohort of people. It's also a framework for aligning activity at all levels. So making sure that, again, from that very strategic level to the service delivery, that things are aligned and are being mutually supportive of each other. And also kind of ensuring and thinking about the idea of kind of a collective responsibility. So, within this, you've got, within each area, looking at kind of implementing or developing and implementing local protocols. There's the senior responsible officer who is responsible. However, it is about coordinating and directing activity across a lot of different areas. So that's a bit of a the protocol kind of outlines how that can work as well. Can move on to the next slide. So in terms of the interface guidance and looking at the local protocol, so the way that we're sort of describing this is the interface guidance forms kind of one part of the wider need, and actually it's a very core part, because it is where those interfaces happen and where the support happens. We say it's one part because if you move on to the next, if you click the slide again. Yeah, so it's kind of supported and underpinning a lot of this is this idea of a workforce development plan. You've got governance frameworks, you've got commissioning strategies. And again, if we move on. So the interface guidance, that can be almost the foundation, because we know, within mental health and substance use, there's going to be existing collaborative practice. There's going to be good practice there. And again, that's something that we'd encourage people to talk about and share today in terms of what existing collaborative practice there is. If we move on. So what interface guidance can do is help provide deeper collaboration and develop more structured connections. So, for example, it can establish mechanisms to stratify need and develop more flexible responses. So, moving away from this idea of condition-specific assessments and and understanding that there is there's a spectrum of need that all needs to be addressed from that system-wide perspective, with the different services within that. It's about it can help establish roles and responsibilities. So that's another thing in terms of where there is that crossover and that collaborative care within that ecosystem of support, within that care network. What are the specific roles and responsibilities? And within that, I guess it's looking at agreeing interventions. So what is it specifically that we would be encouraging people, or that you'd be saying, within this formulation or within this kind of assessment or within this situation, this is what the interventions would be required, and here's how they sort of link together and become, again, greater than the sum of their parts, I suppose, in terms of supporting people with that co-occurring need. And also then we're looking at the starting point of training plans. So, one of the big things is and it kind of links to that idea of stratifying need and there being a spectrum of need, but also a spectrum of support. And we know that from the MAT standards, there's a very kind of a clear understanding of, where there needs to be awareness of mental health needs within substance use services and vice versa. And, we've heard from a lot of staff that while there is an awareness of that, there's a knowledge in that, and there maybe are training plans there, there's a bit of ongoing development and support and supervision that can be used to really kind of bolster that and enhance that. If we move on again. So yeah, and then it can also then look at exploring the external relationships on how you support complex needs. So this is what I mean by it being almost the foundational part. So we've got there looking at inpatient. So, we know that the inpatient support, both sort of general acute, but also mental health inpatient, there are challenges in terms of discharging to appropriate services. And these sort of, thinking a bit again about those roles and responsibilities and those agreed interventions, having that core interface can then, you lead to explore, okay, so how does this interface, how does this understanding of how we support people with co-occurring needs, how does that link with our inpatient pathways, and then likewise with primary care and third sector. So again, looking at what are the various different roles, what is it that we can learn from people, and how do we bring that together. So again, exploring external relationships, how to support complex needs, and then I also identifies almost kind of the limitations of statutory services. Maybe limitations is the wrong word, but looking at what the roles of statutory services are, and because we know that there is a threshold where they're very skilled in supporting certain needs, but where there's co-occurring needs, it might actually be that the link is between your statutory mental health services and your community mental health services and your primary care, but then also third sector as well within that too. So that's kind of I guess where we kind of see it sitting, and where we've heard that it can be a good foundation, and again a good starting point from for this, because again there's a lot happening, there's a lot going on, and we need to start somewhere. And again, what I think will come out from the presentations is that idea of starting somewhere, and iterating, learning as you go, and helping kind of spread that, and starting that conversation and getting other people involved. So next slide. Yeah, so I will hand over now to our colleagues in Forth Valley, who will take you through their experiences of developing their interface guidance and what they learned from that. So take it away.
Thanks, Gregory. It'll be myself that's doing the presentation this afternoon. Hopefully Ross, my colleague, will be joining us and be around for any questions later. What I hope really to cover over the next kind of 10 or so minutes is really just to take you through the work that we've done so far, where we are currently, and I guess the steps that we hope to take going forward. So I've started with just a little bit around Forth Valley so that people kind of get a sense of what services we have in our area. So we are situated in kind of central Scotland. We've got a population of around 306,000, and it is quite a diverse geographical area. We have the kind of Falkirk area you can see there at the bottom is quite urban, along with Clackmannanshire. Stirling is slightly different in that we have quite a large rural population in Stirling, and that does, from both substance use and community mental health, have its challenges in terms of how do we get our services out to people, and also them being able to access services in the kind of three towns of Stirling, Alloa and Falkirk. So the setup that we have is we've got two substance use services, one in the north and one in the south. So one in Stirling and Clackmannanshire and one in Falkirk. We have 3 adult CMHTs, 2 older adult CMHTs, 3 older adult CMHTs, and we have 1 acute inpatient unit that services the whole of Forth Valley, which is based at our main hospital in Falkirk. We also have our mental health acute assessment and treatment service, which again is Forth Valley wide, and based in Falkirk, we've got Bellsdyke, which is a low secure and rehabilitation site. So within our area, we have got 2 health and social care partnerships. We have Falkirk, which is one, and then Stirling and Clackmannanshire form the other health social care partnership. So I think in Scotland, it's the only one that has 2 councils. So it can be quite tricky negotiating both councils and the kind of health services. So that's just a bit around kind of where we sit and the services that we have currently. And if you could move to the next slide, please. So really in terms of the first steps, it was about recognising something wasn't working as well as it could. And that was really difficulties being raised by our clinicians within the teams. So I think there was just a recognition that we were seeing more and more people coming through with significant mental health problems, but also co-occurring substance use problems. And the team were finding it quite tricky and quite challenging in terms of how to manage and do the best that they could for that patient group. Alongside of that, there was also looking at the review of drug deaths, and through that review, that recognition that lots of people had substance use problems and mental health problems. And I think there was a bit of kind of discussion around whose responsibility is it? Do they sit with mental health? Do they sit with substance use? And sometimes it could feel as if patients were going from one service to another and kind of being challenges in terms of how do you manage that? And also thinking about what that felt like for patients, not knowing exactly which team were they going to sit with. So the work started probably over a year ago. There was lots of discussions that were being had within the local teams. And then it was around, what do we need to do about this? We're all sitting with heavy workloads, and we want to do the best that we can for the patients, and we want care to be safe. So what do we do? So I think it was around really the team leads and the managers taking responsibility to act. And what we did was we put together a working party. So that included staff from both substance use services and the community mental health teams, and I think also included the consultant psychiatrists, just to look at what do we do here, what's the way forward. We also devised a staff training questionnaire as well, which was looking at how confident the staff in mental health feel about working with substance use. And that was looking at areas covering sort of confidence in assessing for substance use problems, being able to recognise them, being able to put sort of evidence-based interventions. So the staff training questionnaire was put together and sent out to all staff. And that really was very helpful in terms of helping us identify the gaps in knowledge and skills for the staff within the community mental health teams. What we started to do was arrange interface meetings. So with some of the discussions that we had, we felt it would be helpful to have a specific protected meeting time to bring together staff from community mental health teams and substance use services. So each area has their own interface meeting, and it was about trialling that to see how it worked and the frequency of the meetings and what kind of felt suitable for the teams. So we've had the interface meetings in place for probably over a year now. In Falkirk, within their HSCP, they have weekly meetings. In the north, in Stirling and Clacks, we have monthly meetings. So although we have set up the same system, there are some differences in terms of how we've implemented it. Could you move to the next slide, please? So the outcome of the work is really that we've had a lot of joint discussion. So there's been lots of time set aside to look at how we want to work together, thinking about the patient journey, thinking about the staff needs. And we created a draft interface guidance document. And that was done between the kind of managers, so Duncan, who is in the same role as I am in Falkirk, and who's one of the clinical nurse managers in substance use, got together, started putting the document together, and I kind of came in on the back of that. So we put the document together, looking at how communication was going to work and about levels of responsibility. And we took that through our clinical governance process. So the clinical governance process is quite an important part of it for us. Each area has a local clinical governance meeting, and teams are able to bring things to those meetings. We can have lots of discussion, but in terms of creating kind of operating procedures, they have to go through the clinical governance process. So our draft document went to each of the local area meetings for them to have a look at and to get any comment or suggestions. And that then has to go through a higher level clinical governance meeting before it can be signed off. Once that was done, we were able to share the document with the teams so that they have that information there if they need to check anything. And that kind of document really forms the basis of the interface meetings. Next slide. So where we're at the moment is we have our interface meetings with the substance use colleagues every week or every month. The purpose of those meetings is where we can discuss referrals between services. If we have a challenging situation and we're not sure what to do, we can seek advice and information, and that works both ways. These meetings are open to all the clinical teams, so they will have band 5, band 6 nurses, team leads, pop along to ours as well, and we also have input from the medical staff at those meetings. So I think staff find it really quite helpful if there's something that they're not sure about. What we are planning to do now is to take forward, we've got a meeting arranged to look at how we're going to start collecting some data from the meetings, because it's important to think about that from a clinical governance side and to make sure that we are kind of monitoring and checking information. So we've got a meeting arranged to be clear on what data do we need to collect for the MAT9 standards, but also we have involvement from staff member who works with Pentana. So what we find is from work that's been carried out so far with the other MAT standards, there's quite a lot of information that we can put onto Pentana and hopefully be able to pull some additional reports. So I'm hoping to be able to draw up action plans that we can put onto Pentana to kind of ensure that we've got a kind of framework for the work that we're doing. And it can help us to measure outcomes and look at the reports, hopefully giving us lots of different information. Our teams work with Care Partner for our kind of notes, our clinical notes. So we're looking at setting up some coding for Care Partner so that when we have the interface meetings, there's a kind of specific setup for being able to document that. And we've recently found out that we can have Care Partner speaking to Pentana, hopefully, or that we can pull some additional reports out of Care Partner again so that we can see How many referrals are we sending to SUS? How many are coming back from SUS? How much information sharing or advice are we seeking? The other big component to the work that we need to look at is staff training. From the staff training survey, what we identified is that there's not a lot of confidence in terms of staff working with substance use within the mental health teams. So what we've begun doing is that both areas in Falkirk's HSCP and the Stirling HSCP is that we have dedicated training sessions for staff anyway. And what we're doing now is that we are beginning to introduce some additional training. So there's one planned for January in Falkirk, which is around cocaine use. And it's about upskilling staff in terms of knowledge and skills. So we're planning to continue to offer additional training sessions. And it may be that some of the mental health team staff go to SUS to provide additional training on aspects of mental health. We're also hoping to kind of set up and support staff to go through those various kind of TURAS modules. And again, just periodically checking in with staff with regards to training and confidence around how we're working with substance use within the CMHTs. The plan is to have ongoing partnership working across the services and the two health and social care partnerships. So to achieve this, both Duncan and myself meet on a regular basis. We have the same role, just in different partnerships. And it's about having that ongoing support and working together so that we can ensure that whatever we're doing is kind of across the area. There should be really no difference in terms of, you know, how people can access services. We may implement things slightly differently, but it's around whichever area you're in, you should have the same access. And I think it's going to be one of those things that is going to continue to evolve. I think the more that we work together, the more information that we are able to pull, and we're able to kind of review the information from the reports, will help us continue to develop how we're working. Next slide, please. So I think the wins that we've had is that the changes were very much staff-led. We were aware that there were some gaps in our service. There were gaps in knowledge, and actually staff told us this and we listened. I would say that there's been sort of positive leadership, that we have heard the difficulties and we've responded to that, and we've involved the staff teams in it so that they have ownership of the meetings, and they are now really feeling confident with taking stuff to the meetings and asking for help and support when needed. It's improved relationships across the service. We've become more aware of the gaps, and the whole thing's really been underpinned by clinical governance. And hopefully we'll get a lot of data out of it as well. So that's where we're at. Over the last year or so, we've put in quite a lot of work. We feel that it's working really well, the feedback that we're getting back from the staff teams. And I think we all feel quite positive about going forward. We know that there's still a lot of work to do, but I think it's, for us, it's very much about that team working and listening, and making sure that we're doing the best that we can. That's all I've got.
Brilliant, thank you, Leanne. I think it was a good overview of what you've been doing, a good walkthrough. I think it's particularly interesting to hear about that the importance of having those spaces for people to ask for that advice, and the role that has on the relationships between people, and also having that kind of staff leading the changes, and kind of making sure that we see what works. Thank you very much.
I suppose the other thing to say is that within our substance use services, they work alongside CGL, which is Change, Grow, Live. So they have quite a tiered service. So I think as well what that's done is it's helped build those relationships between the community mental health teams and both kind of third sector and the kind of statutory services. One of the other things actually I should have mentioned is that one of the other aspects that we have is we have a MAT steering group. So the MAT steering group really covers lots of staff from the council and health board and third sector as well, and it kind of covers all the MAT standards. So when we go to that meeting, it's every couple of months. It can be really helpful because people are at different stages of working in each of the MAT standards. So for me, just kind of coming in and taking more of a role on the MAT 9 standard, it's been really helpful to hear how other people are developing the work that they are doing and how they're kind of collating the data. So we have that every couple of months, which is just to ensure that we are kind of keeping on track with the work that we're doing. So I suppose that's an important additional thing that we have in place to kind of ensure that we're heading in the right direction.
Brilliant, thank you. We've had some questions in the chat, but as I said at the beginning, we'll save those for the panel discussion at the end, but they will definitely come to those. Yeah, brilliant. So we'll move on now to the West Lothian example, which it be led by Laura and Lindsay, who will tell us about, again, their experiences in the role of relationships, and how you support the dialogue between staff and the role that has in developing that shared understanding, which can then lead to the interface guidance. So yeah, take it away, guys.
Thank you. So my name is Lindsay McLean. I'm the manager for the community mental health team in West Lothian.
Hi, and I'm Laura McNabb. I'm one of the CPNs with the Community Addiction Service in West Lothian.
So just to give you a wee bit of background information, when I started working on the MAT 9 activity, I was previously working within the Community Addiction Services as a CPN. I put my name forward to do the joint working with the mental health team on the activities because I had a genuine interest in trying to help improve access to mental health services for the people that I was working with within the substance misuse service. I was paired up with 2 other nurses, so the CMHT team within West Lothian is actually split into 2 teams. So we've got a West team and an East team. So we had somebody representing each of the teams. So the 3 of us worked quite closely together, and we did keep it really quite small at the beginning. I think what's important to know is that actually we did try and do some of this work probably about 10 years ago, but it wasn't as successful as it's been recently. There was too many people involved in it. There was a lot of pressure about trying to get it in and get it implemented and working really fast. And there was some positive outcomes that did come out of the work that happened before, but there was a lot of different opinions on it, a lot of people kind of pulling it in different directions, and there wasn't a lot of shared understanding on what each other's roles were, the responsibilities, what skills people had as well. And I think that that's really important. Because actually we need to look at what worked before, what's working now and what didn't work before, and how can we improve on that. And it is really important that we learn on that, because actually the people that we're working with, they're experiencing multiple assessments, which can be really distressing for people. There's barriers to accessing services. People often feeling that they're feel let down with services. What's the point? It can delay treatment as well. When referrals can be turned down or not accepted by services. Often what we were finding before is that we were putting referrals in, we were sending it across to the service, and then we were getting a referral response, but there hadn't been a lot of communication about that referral, so a bit of misunderstanding about somebody's situation when you were putting a referral in for somebody you were working with. And that's really difficult when you've got somebody in front of you, you've maybe really supported them and spoke about the options available to them, and then you're having to go back to them and feed back to them that actually that referral's not been accepted and we need to look at other options. So that can be really difficult when you're naturally wanting to try and help people with as much as possible. The next slide, please. So to start off, we really focused on the relationship and getting to know each other. There's lots of evidence available for building relationships and how to do that. But really, I think naturally when we were trying to get to know each other, we really kind of welcomed each other into the team. When I went across to the CMHT team, I felt like I was part of the team, to be honest with you. Like, they really were like, oh, this is this person, introduced you to everybody. You were accepted within the MDT, you were encouraged to participate as well. So it was really that welcoming feeling that you were getting. And actually, when I was preparing for this presentation, there's a man called Jan Gunnarsson who's an author that talks about relationships and having that genuine hostship by being open and honest and listening and sharing knowledge. And I think really without us knowing, that's really what we were doing, is when the working group were coming and shadowing each other, actually you felt that you were being hosted, you felt like you were going in, you were welcomed, and actually you wanted to go back again and learn a wee bit more about the next time. The next slide, please. To get started off, the idea really came from our service manager. He was really encouraging us. He manages both addictions and mental health teams, so he was really the driving force for us to kind of starting this off. He gave us protected times, which was really important because we really needed to get to know actually what's available out there. How do services work? What's the referral criteria? How do we link into inpatient services? How do we link into emergency services? What are the third sector agencies that we can link into as well? And all the people that were really involved within the working group had a personal interest in getting to know all of that, because these have been things that they'd found really difficult in the past, and actually having that knowledge and understanding of all the different areas and services within West Lothian was really important. And I think like when I was going out and shadowing the different services, I was coming back to your team and I was feeding that back within the teams, and people were really keen and interested to hearing all the updates. It generated a lot of discussions and reflection, and then I would then take that back to the working group and discuss that with the working group as well. It really felt like it was something that was really valuable. It felt like the change was really coming from it, and I think like that's why we kind of say go where the energy is, and I think that that's been something that's been really important in building the relationships with the CMHT and the addiction services. Research shows that having a process such as having an introduction, coordinating care with communication and joint working builds trust, but it does take time. And I think that for us, what was really invaluable was actually working at the Quality Improvement Academy. So the three members of the working group actually signed up to a Quality Improvement Academy where we had to work together to develop joint aims and ideas and test that change, but it was something that was going to be implemented within each of your services. So it was something really valuable and a practical thing that we could work on together. And whilst doing that, we really had to trust each other. We had set targets for each other. We worked, we really had to work together really to pass the competencies for that activity. So it did really build up that communication between us, and we were working really closely together on the care plan project that we were working on, and that really built up that relationship at that point. Next slide, please.
So this slide shows some activity feedback from a kind of working from a larger group in the mornings. So from the smaller working groups, that highlighted some gaps in the understanding of roles and service criteria. from both the Substance Misuse Service and within the CMHTs. So we had networking mornings, which we've had a couple now. And again, this was hugely supported by our management. They even included breakfast for us. And this was greatly intended and had a lot of enthusiasm from all three teams. This allowed us to explore a point of assessment and look at referral criteria and processing services. It also allowed us a larger networking service and just some face-to-face contact to actually put some faces to names and to roles. These smaller groups organising these kind of networking mornings had included a larger group of again, it was nurse-led, but we had OT and social work input, and the managers took a step back, obviously giving us the protected time, but allowing us to kind of process that further. And it also gave us a platform to start introducing the interface document and start giving that out to the wider teams and feeding back some of the things that had been done in the background, really, in the smaller working groups.
Next slide, please. I think it really felt like we were a part of something important. It was really valuable. It came from us rather than something that we had to do. So I think there was a lot of ideas around about what would work, what would be useful, what could be helpful when integrating and communicating with each of the teams. We had practical things like the care plan that we worked jointly on together. We had the support groups as well, where you could organise an appointment with somebody of the opposite team, like the addictions or CMHT team, where you could actually just have a safe place to talk about somebody who you were worried about, run questions by them and say, this person maybe doesn't want a referral into addiction services or doesn't want a referral into mental health, but this is actually what we're really worried about. Is there anything that you can give me any tips or ideas with, and have that real opportunity to share our skills and our knowledge on the particular complex cases that were being discussed at that point. The away days for the team were really, really well fed back. The team really enjoyed them. They really got to know each other. And it gave us a platform for dialogue. We were able to look at the referral criteria and actually understanding why some referrals weren't being accepted and actually who was more appropriate to be referring into, and learning a bit more about each other. There was good foundation for us, really, so we were all supporting each other, and I think everybody in the room was really wanting the change to happen, which was good. Next slide, please. So in terms of developing the guidance, the general manager was the main drive on this, but actually what we've done is we contributed a lot to it. So he was asking us for our opinions, we fed back on the processes, we spoke to him about things that we had changed in order to actually make it a bit more streamlined, a bit more easier to refer into certain services like at the hospital or outpatients as well. It gave staff a real opportunity to give a better understanding on what's really helpful when you're trying to support people into mental health services or from mental health services across to substance misuse services. And I think having that joint discussion and that safe place to actually say, this is helpful, this can be a barrier, a lot of people find this frustrating, and actually advocating for the people that you're working with to say, actually, this is what people feel like when they're having to go through that process. Can we maybe have a look at that? And it was really valued in anything that we were coming up with. You really felt that people were listening to, and I think that that's really what's important in terms of being able to drive the interface guidance forward for the relationships. Next slide, please.
And just kind of obviously, it has been hugely successful that we've managed to get the interface document out, but obviously there has been some challenges along the way. There was limited medical input and we're ready to embrace changes. I think there's that fear sometimes of opening floodgates, and obviously staffing levels even of the working group, because things evolve, things change, staff get different roles or their sick time, and also just it was a mixture of kind of Teams meetings and face-to-face meetings because they're all staff working in different areas and different bases, so that could be challenging at times. There was also some enthusiasm from other areas and really wanted to be involved in the group, but we had to very much VIP list it to get the foundations down and things on paper before we start extending that further. As Lindsay indicated earlier, that past experience had said when it was a larger group that it was harder to get things in place and lots of discussion and very little action. So it was very much sticking to the VIP list. And obviously there's still pressures from our external agencies to be involved in the processes. And I think sometimes there was ongoing frustrations that there was lots of meetings and lots happening behind the scenes that wasn't always fed back to the smaller teams. And I think it's taken some reflection on that and feeling like you're having all these meetings, but nothing's changing at the front door. And I think there's been some reflection in the highlight needing to feed back as we go along. And I think that's why the networking mornings were so important to kind of feed some of that back. Obviously, as we move forward, we've looked at change has been slow, but it's been steady. As I say, this has been going on for what, over
The years,
couple of
2
years,
years.
yeah, of kind of this smaller group building it up and, you know, being able to put it down into the interface. There's been more thought, therapeutic working relationships between services. We're more identified to roles within the services and different multidisciplinary team meetings. There's been client feedback that they're now finding we're working better together and they're not repeating their stories. So there's better integration for them. Obviously, we've got a lot of work to do in expanding it into other mental health services. We've very much been substance misuse and the community mental health teams, but obviously we have to spread that out over the whole of mental health. Continue the working groups and not to lose momentum, because it's like one bit's working well. How do we get that to work somewhere else? And keeping that momentum and keeping that enthusiasm. And that's about people being involved who have a drive for it, as Lindsay indicated at the beginning, and continuing to review the work process and making sure it's valued by the staff and the services. So actually that the interface is getting used and that people are getting access to the right services at the right time. And obviously trying to embed that guidance to just becoming a natural process. It's still stickly as it is in other places, and sometimes people still find it at the wrong door. So it's about that becoming a natural process. So we've still got a long way to move forward, but we've got the start blocks of.
I think in terms of the relationship, it is absolutely about starting off small and then it kind of naturally gravitates out to everybody else within the team. And now that we're at the point where we're kind of opening it up, the working group's expanded so far at the minute, we need to expand that a bit further into other agencies, actually. But the ethos of the working group that we've got is that we want it to be change is important. It needs to work. And actually, if you want it to work, you need to put the time there and protect that. Change is going to be slow, but actually if it's worth it, it's actually, that's what you need to do. You need to go that way. There's no point in running at something at 100 miles an hour and actually it doesn't work. It needs to have a purpose and it needs to be important to people, and people need to feel that they've got a say in that as well. And that's really what kind of makes people want to kind of work in the way that we've been working, because it's valued within each of the agencies. So that's us, really.
Yes.
Thank you.
Brilliant. Thank you very much. A lot in that as well. There's some questions that I've got that I might put in the Q&A chat as well, because I think it'd be good to hear a bit more about some of the activities that you outlined there. So I think it's time for the break. That's 3 o'clock. If everyone had a chance to stand up, stretch the legs, get the blood moving a little bit for the second half of today. We'll continue the presentations before getting into the breakout. And again, I wouldn't say it's just a reminder. I think we've had a couple of really good questions in the chat, and so please continue to add to those. And again, we know this is quite, it's very complicated stuff and very detailed and quite wide ranging. So if there's anything that you want more information on and stuff, that's the perfect place to do that. And as you can say, we can respond to some of it as we go. As you say, I can see Ross has replied to some of the stuff around the Forth Valley work there. So much appreciated for that. I'll introduce Peter and James. So Peter MacArthur and James Hill from North Ayrshire to go through that. And again, I think we've heard about kind of some of the structures around how the processes through which things get developed, the kind of conversations and relationships and forums for that. So I think, you know, this is moving more into that kind of implementation space, and I think the role of leadership in enabling a lot of that practice, and kind of role modeling some of that too. So I think it'll be a really good way to kind of round out the presentation. So Peter, James, over to you.
Yep, thank you. Hi everyone. My name is Peter MacArthur. I'm the Senior Manager for Alcohol and Drug Services in the North Ayrshire Partnership. And co-presenting today is also James Hill, who's an Advanced Nurse Practitioner and Acting Senior Manager. Thanks to Gregory and others for suggesting our presentation today. There's many people at the webinar I've connected with recently through regular MAT standard discussions, but today, however, we've been asked to highlight how we have used in North Ayrshire senior leadership and role modelling to positively implement our refreshed interface guidance, and that's across health and social work and social care services in North Ayrshire. So if I could maybe get the next slide, please, and I'll pass over to James.
Hi, thanks for that, Peter. Hi, everyone. My name's James Hill. I'm the Acting Service Manager with NADAR's Addiction Services in North Ayrshire, also AMP for the other part-time role. So just to kind of go into our kind of background and our kind of previous kind of interface protocol and currently our North Ayrshire setup. As it stands in our setup within North Ayrshire, we have our own integrated health and social care, secondary care, alcohol and drug recovery service, which is NADARS, that both myself and Peter are involved with. Within this service, it includes, you know, 20 plus mental health professionals, RMNs, registered mental health nurses. We have occupational therapists. We have 2 and a bit AMPs. We have 2 consultant psychiatrists, 1 GP specialist, and 2 psychologists currently with the team. We also have a number of staff who are not trained with regards, you know, RMNs or OTs, etc., who also provide valued support throughout the service. As Peter says, we are an integrated service, so we also have social care staff, and we have social workers within that team, and they will lead on, you know, ASPs, child protections, AWIs, etc., going forward. Again, in Ayrshire Nairn, we have an integrated health and social care, secondary care, community mental health service, and that also incorporates the intensive community psychiatric nurse team. We also have a community elderly and learning disability services. In Ayrshire Nairn, we're quite unique in the sense that we have a mental health inpatient facility, Ward 5, which is based within Woodland View Hospital in Irvine. It is an alcohol and drug treatment ward that does provide, you know, detox, both alcohol and drug. It also provides, you know, inpatient rehab or day attendance rehab. And this all comes under the management, which is supported under the Mental Health Directorate within the North Ayrshire Health and Social Care Partnership. Can I have the next slide, please? So, obviously, the senior nurse group agreed to update our existing interface guidance document following the Mental Welfare Commission's report and the direction of travel that was kind of sending us down the road of. And that was to look at the ending the exclusion for people with drug and mental health issues. We were looking at there being no wrong door, which kind of ties in very nicely with the MAT 9 standards. What was the goal? So the goal for us was to provide a quick, non-complicated, no barrier, easy access to support and treatment for those individuals, complemented by the existing support via our current mental health and addiction, alcohol and drugs team. And that included supports from primary care, commission services. In North Ayrshire, we have Turning Point Scotland. We also have a wide variety of recovery focus groups which are also run by some of our recovery development workers that currently are working with the team here in NADARS, and they would lead on those recovery groups. We also have the Recovery College. As part of this, we also felt and continue to feel it's essential that we involve service users, families and carers within, our interface guidance going forward. So what did we do? We set up an initial operational group to review our kind of current guidance. Next slide, please. So who did we bring together in this group? So it was a group made up of senior managers, team leaders, professional leads, and they reviewed the content and the language of the current guidance. As you know, or most of us probably know, we used to go under the name of dual diagnosis, and the language of that quickly changed, and rightly so, to our co-occurrent mental health and drug or alcohol use. As part of that review, the guidance, we looked at wider and national reviews that were going on at that particular time. And from there, we created a new guidance. The new guidance is supported by the Health and Social Care Partner Director, and the group is chaired by our Head of Service within Mental Health Services. And that consists of senior managers, team leaders, clinical staff, professional leads across all the key services. We also have the kind of lived and living experience, and we also have the information management and technology group to support any data that is required from that. I'll hand you back to Peter. Thank you.
Thank you. If you could maybe on the next slide, please. So similar to the previous presentations from Forth Valley and West Lothian, some of the phases that I'm just going to go over certainly complement some of the earlier points that's been made. So initially, team leaders and team managers from across health and social care services, clinical staff, tested out, this is the role modelling bit, the overall guidance. There's lots of different scenarios that can be faced, as I'm sure all of you know, but the purpose of that was to gather feedback from that initial phase. And the main feedback fairly quickly was the level of detail was perhaps too wordy and overly complicated, trying to be maybe too many things. So the overarching steering group pushed that back to the operational group, had made the comments, and they updated the guidance based on their own feedback, and that guidance was then agreed. To kind of raise the importance of it, we then arranged jointly by senior managers across the alcohol and drug services and mental health services, myself and others. We delivered staff awareness sessions. That was done over a 4 or 5 week period. There was over 200 staff attended. That was mainly facilitated through the teams, and it was multi-service, multi-agency staff across statutory and other services. At that point, the next phase then was to implement, test out. The instruction bit was to say, you see if you encounter any immediate difficulties, feed that back immediately so that we can very quickly review that and update the guidance, but also to balance that to keep any and feedback any examples of good practice. Again, the next slide, please. So the feedback following that, there was fairly minor changes, and these improvements were made very quickly. A number of examples of good practice, joint work, integrated work across health and social care was provided. So we're currently on that kind of implementation phase, and we've got next steps, which includes, that's the support through our staff that support us with our systems, data recording and service improvement. There's an audit review, and again, the goal for that's to improve outcomes. Accompanying that, the overarching steering group had other improvement actions to run complementary to this. So it was really important to get experiential feedback from individuals with lived living experience, from family members and from staff. That's been used to look at what other areas of improvement is required. We looked at shadowing opportunities from staff across services, and that's been picked up by staff, and networking forums across services. That's across role specific, so consultant psychiatrists across services are meeting, team managers, team leaders, down to operational nursing staff, social work staff, etc. meeting, and that continues to be promoted. And other areas of improvement as part of this wider interface guidance is looking at improving the recording of and diagnosis on the relevant system. So the kind of promotion here is we wanted this development to be inclusive, we wanted it to be positive, and we would suggest that through leadership and role modelling, that's increased partnership work and has increased awareness across services and staff and service users and family members, with the aim of delivering on this interface guidance to make this thing so much easier for individuals who require mental health and alcohol and drug support. The next stage, as I say, is auditing that in more detail. There's a programme of work to accompany that over the next year, and we'll then take that information to look at learning and improvement. Thank you, Gregory. I'll maybe pass back to yourself.
Yeah, thanks very much. Really interesting to hear about that experience, and specifically looking at, I guess, that the relation with looking at some of the more kind of national direction of it, and how that was brought in, and then again that kind of very quick iteration in terms of getting that immediate feedback. Because I think again one of the sort of messages really across a lot of this is just trying things out and not being too worried about it not being perfect to start with, and also that the comment about I've forgotten now. Yeah, but it was, yeah, thank you very much, Peter. And James, sorry. So in terms of the breakout discussion, so we're going to be in breakout rooms. So there's a lot of people here. So the what would be really useful to talk about is basically reflecting, sharing your experience with interface guidances, if you have any. But that's also potentially with, you know, sharing experiences with the idea of an interface guidance. So in terms of is the discussion starting even in where you are, and it's kind of thinking about, you know, when you get into the groups is basically asking, you know, who has interface guidance, what stages are people at in terms of that. A key question to, you know, that might be helpful to find out is where did the decision come from, and then what was people's processes. So, you know, what services were involved, where were decisions made. Basically it's kind of just to help people get advice on what might need to be done to get that conversation going, to build that momentum. And if you know there's no one who has that interface guidance or is on that journey, it's almost starting to, where are you? You know, is there any good practice that can be built on, that can be developed? You know, are there any conversations that are happening? You know, we heard about the role of that kind of emergent conversation. So what kind of things are happening there? Is there any tests of change that are going? So just kind of, yeah, reflecting and sharing those experiences with either formalized guidance or just with that idea of collaborating with services. We've got 15 minutes of this, so it's going to be randomly whisked away into various groups. There won't be, because there's too many, there won't be a dedicated facilitator for each group. So just have the conversation that you need to have. There's no real need to feedback. It's just a space for you to network and ask questions and to, you know, have that discussion. So I think we'll get whisked back here in 15 minutes, ready for the panel session. So I think if we open the breakouts, I think it should, yeah, people should be sort of automatically redirected. I think one of the things that we often talk about is sort of creating the conditions, and I mentioned at the beginning that the protocol is a bit of a framework for making sure that we're bringing together different agendas. So while interface guidance, as you say, is a very particular part of that, one of the things that we're encouraging people to do is keep that broad vision of this is one part of it, it's one interface, and actually when you are thinking about expanding that interface, what work needs to be done within the third sector itself to make sure that it's there and it understands, and that there is an understanding of what that kind of offer is and what that interface looks like and how that might all work together, so that then things can sort of dovetail. But in terms of this particular one, want to leave with some sort of next steps really, and to help think about what to do after this session. And the speakers that we've heard today, we've written up the case studies that give some of that background on that will be available after this. They've also kindly shared their interface guidance with us, so that will also be put on our website. We'll share the link in the chat so that you can actually have a look at when we talk about this stuff, what does that actually mean in terms of writing it down, what kind of words you use, very practical things like that. And one of the ways, in terms of bringing those together, I think one of the things that kind of came out was this sort of this flow of activity that seemed to define a lot of it. And it's starting off with that groundswell. I think someone said it's like, first it's realizing that there's an issue, and a lot of that happens. People will be having these conversations already around what needs to be done, where there are challenges. So it's about understanding that. It's about taking that and then putting some oversight and sponsorship around that. So again, there was a good example in West Lothian about having that sponsorship. So actually the service manager saying, yeah, do it. I've got your back. I'll make sure there's protected time. I'll give you those connections. And there's also that sponsorship in terms of saying, taking it to other groups and saying, these things are happening. And then there's the development. And that's almost like, okay, so we need to do that. And then there's the development and iteration, different ways of doing that. But again, I hope that the message of that kind of testing, trying things out, having those conversations really came up. And then, I suppose the refine and spread was less spoken about, but in the written case studies that were shared, there's, in terms of that next steps, in terms of kind of refining it, and as we said, the spread in it. So, consolidating the interfaces that we've got, and then actually having a look at to say, well, what's next? So I guess with that narrative, it's, I suppose, one of the things that I'd ask you to do is where do you think you are in terms of that, and your colleagues? I'm aware that on the call there's people from across the system and different services. So yeah, just having a bit of a think about that, I think can be a useful start. Let's move on to the next slide. So, and then it's thinking about, so where are you, and do you need to start or structure conversations? So having to think about what forums do you have where staff have the opportunity to connect with each other, and that's staff at different levels, but that's also staff across different services. What are the conversations that clinical staff are having about co-occurring conditions, and how best to support people, and in that very much live cases, problem solving kind of frame. What work's going on within services that could be supported? So again, is there any, one of the things we always say is there a workaround that people are doing in order to, make things happen? And could that be supported? Could that be formalized? Where's the good practice that's happening? One of the other things is who are you almost clinically credible leaders who can bridge the gap between sort of clinical staff and management? So, talk about that. The role of the clinical governance groups in sort of signing that stuff off, and I think in one of the examples there was a very clinical people hearing those conversations, but because they have those links with that kind of higher senior management, we're able to bridge that gap. And then next slide. And then once you've had that, do you need to, another option might be, or another thing might be that you need to build the coalition. So you're aware that the conversations are happening, but you need a bit of structure. You need to bring people in and have that. So a lot of that is almost basically potentially just finding sort of almost excuses to get people together and around things. So is it a case of needing to jointly review existing documentation? It's about having a review, unpicking a bit of that. What oversight groups do you have already that could maybe be used as a focal point for this or could be expanded? And again, is there a focal point for sort of the breadth of engagement? So that's, you know, conversations across a range of services, but then also the depth of engagement. So actually, you know, really drilling down to have, you know, clear engagement with staff, and I think as John mentioned, that having those forums for, you know, band 5, band 6 nurses to get together and talk about some of the issues that they're facing. And the other thing, are there identified champions? I think, you know, across it, in all examples, there have been people, you know, within a mental health service who's taken a special interest in substance use and how to do that, and vice versa, you know, and people who have been champions. So have you got that, and how do you bring them into the process? And then, so I guess the final one in the final slide of this section is, if we could just move on, is the call to action. So moving on again. So is talk. So creating spaces at all levels, open conversations up at team meetings, get managers together to build that shared understanding. Think about priorities. So you're likely to have priorities already, and, you know, is it possible to get people together to start unpicking those specific ones and share these conversations that you're having with people? And then the next one I'd say is connecting. If we move on the next slide, so is creating routes for advice between services. What conversations are different groups having, bringing people together around that, and then consolidating these conversations. So making sure that you're writing this down and it's kind of pulled together again into some sort of framework. And then finally is testing. So is, you know, trying things out and reflecting. One of the things is empowering people to say yes more. So as I say, if there is something that a person's being, you know, how do you say yes to the person in front of you to get them the support? But then also, you know, don't wait for that big bang. You know, it's never going to be perfect in the first draft. So it's about taking it out and testing it, bringing it back quickly and refining that. So that's, you know, in terms of this interface guidance, that would be kind of the main sort of calls to action. And then if we move to the next slide, in terms of the next step, so after this, as I say, we've got these case studies, and we'll share those with you. We're also having another learning event, which is our clinical network. So, and that's going to be looking at responding to substance use, stimulant use, sorry. And, you know, we know that that's an increasing challenge for people. So we're going to have some speakers to talk about, you know, what the potential approaches to that might be, and you can register there. And then finally, would really encourage you to provide feedback. So we've got there should be a link for some online feedback, and that's really useful just to hear us to hear about how you felt today went, and that'll help us improve these sessions and make sure that they're providing what you need, because hopefully we'll be having more and expanding the kind of topics that we'll be doing. So we want to make sure that we're responsive to what people need. And finally, thank you very much to our presenters and our speakers. It was really great to hear what he's done. It was really great to get that kind of real life experience of, you know, what actually all this is likely to involve. So thank you very much, and thanks to everybody who attended and listened and contributed. Looking forward to kind of, you know, continuing this dialogue. If that's something you're interested in, please get in touch. It'd be really great to keep talking. So thank you very much, and see you all soon. I hope you have a good rest of your day and evening. Thank you.